Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network at the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being here with us today on November 14th, 2018 for this RN and Allied Health Telehealth lecture. Let's see, what can I tell you before we get started? If you are having any technical difficulties at all, please don't delay. Call us at 919-445-1000. You can also email us at unccn@unc.edu. Let us know what's going on. We have technicians standing by who can help you if there are any technical difficulties whatsoever. We're on Facebook, we're on Twitter, we're on Instagram, we're on YouTube, and you can find us on the web at unccn.org, and we're proud to have made the transition here at the UNC School of Medicine from Plone to WordPress, so we have a whole new look and feel to our web pages, so please take a look at that. All right, let's get through a few preliminaries and get started with our lecture. We'll be using Poll Everywhere today so that you can both answer questions that our presenter will be sharing with you, and she has several during the lecture, and then at the end you'll be able to use Poll Everywhere to share your own questions with the presenter. So we hope that you'll do both. That really makes for an even more engaging lecture when we have our audience responding and participating. It's very simple to do. The easiest way to get into Poll Everywhere, if you have a computer with a web browser on it or a smartphone, just go to pollev.com, that's pollev.com/UNCCN. And I'm really pushing this way to use Poll Everywhere. As more and more people do have smartphones, again, you can go on your web browser, pollev.com/UNCCN. As the questions come up here in the studio, you'll see those same questions and be able to respond to those. Now, if for any reason you feel more comfortable using phone's texting mechanism, you may do that as well. And that's easy. You just text the number 22333 to the number 22333, the letters UNCCN. You do that one time. You'll get a little response back saying that you've joined the meeting today, and then you can answer with letters or type in questions as the questions occur up on the screen here. So you're in the to field 22333 and the message field UNCCN to join. Do that one time, and then you'll be joined. All right, so one of those methods, we hope you'll be using Poll Everywhere. Our first Poll Everywhere question, I think this one is one that you'll get, although these are all anonymous, but UNC's Adolescent and Young Adult AYA Cancer Support Program helps patients in which age range? And so if you think that's from ages 1 to 70, you put A. From 1 to 13, B, from 13 to 30, C, or from 13 to 70, D. And we'll put up that actual poll in just a moment. So without further ado, I want to say welcome to today's presenter, Laura Lux.
Thanks.
Welcome.
Thanks for having me.
Thank you so much for being here today. So let's see what we know about you already. Licensed clinical social worker.
Yeah.
Hired as the AYA program director here at UNC in October of 2015. So you've passed your 3-year anniversary.
Yeah.
Okay, congratulations.
Thanks.
You meet with patients and families and are continuing to grow and develop the program, the AYA program. As the director, you're focused on direct patient care, psychosocial research, program development, education, and advocacy. Great. And then you're involved in development of AYA provider education across the U.S. Tell us a little bit about that, if you would.
So there's some really exciting stuff going on in the state of North Carolina where we're trying to reach out to providers across the state through sort of venues like this, and also just as a plug, we have an AYA provider symposium in the spring. This coming spring will be April 5th. For anyone from around the state to join, the cost of registration is very low. We want to encourage as many people as possible to be there. So we're also involved in partnering with some other organizations throughout the U.S. to try and raise everyone's knowledge level about how to care for adolescents and young adults.
Right. Great. Well, thank you so much for the work that you do. It's very near and dear to my heart, and I really appreciate all that you do. And thank you for being here to present to our audience today. So let's take a look. We've already have some responses coming in. Looks like there's something about that 13 to 30 years of age range that is clicking for our listeners. How are they doing?
Fantastic. Smarty pants group of people.
Good deal.
100%.
Good deal. So 100%. Yes, that is the AYA range is 13 to 30. So, okay. And without any further ado, the gift of Sophie, how UNC is transforming care for AYA patients and survivors, and how you can too.
Thank you.
And we pass over the controls to you.
Thanks.
There's the cursor if you need it.
Thank you.
All right.
Well, I can't start any talk about our AOA program without first explaining why our AOA program exists. This is a photo of Sophie Steiner, who is a 14-year-old who was treated at UNC several years ago. And unfortunately, she passed away. We were unable to cure her cancer. And she was so happy with the medical care that she received here, but she felt like as a teenager that we weren't doing the best job of taking care of kind of her whole self and who she was as a person. And she really hit the mark on that idea. So around the time that Sophie was sort of saying these things to her parents, the rest of the U.S. was waking up to this idea that adolescents and young adults, and we'll kind of define that age range further in a little bit, really have different needs than younger cancer patients or older cancer patients. And Sophie's family, with the help of an amazing community in Chapel Hill and beyond, established the Be Loud Sophie Foundation, whose sole purpose is really to fund our program here. And we are incredibly grateful for the legacy that Sophie left and that her family has been able to carry on throughout the last few years as they supported our program. So I also like to start talks with photos of our patients, and I think that we do a lot of work in our adolescent and young adult program with research and education, quality improvement stuff in the hospital and beyond. But what it all comes back to is our patients and their families. And this is a 26-year-old who is treated here and his daughter. And he was in the military. UNC takes care of a lot of military folks and their families. And this was his reason for getting up and coming here every day and completing his treatment. So I think we often think of the teenage or the adolescent part of the AOA age range, and we don't always think about the young adults. And it's really important to keep them in mind as we're going through this talk. Here's one of our amazing teenagers talking about when she lost her hair. Another amazing young adult who told a story about her grandmother and hot dogs that if we had more time I could go into, but it was great. So I think it's really good to remember that these are people, they're real people who have lives outside the hospital, and how can we focus on those lives as we support them throughout treatment. The first thing I want to say about taking care of adolescents and young adults is that you don't have to be a lot of things. You don't have to be cool. You don't have to be up to date on recent slang terms. You don't need to use Snapchat. I have no idea how to use Snapchat. You don't need to be young, and you don't need to be cool. So I think that this age group can be a little bit intimidating for people, and I think that a lot of providers have this idea in mind of the kind of person that can take care of adolescents and young adults, and I think it's good to dispel that myth early on. Here's what you have to be. You have to be really authentic and flexible, compassionate, honest, and willing to get to know the person and not just the patient. If you have teenagers or young adults in your house that you're raising, or you know teenagers or young adults well, they call a spade a spade. So you have to be really authentic with them and honest about what's going on. And I have found that you'll get that same honesty in return. So just a little bit of background, kind of what's this adolescent and young adult business all about? So the National Cancer Institute refers to adolescents and young adults as 15 to 39 years old. And we're going to talk a little bit about where that age range came from in a minute. There are 70,000 new AOA patients diagnosed each year in the U.S. Clinical trial enrollment for this age group is minuscule, and we will talk more about that as well. So it's important to understand that in the pediatric world, for patients between the ages of birth and 15, clinical trial enrollment is quite high, 60 to 70%. Once you get over that age range, at that 15-year-old age, that number drops. And again, we'll talk more about this, but that affects their survival. They have less access to support services, high financial toxicity. If you think about what's happening in this stage of life, they are not often financially secure. And then you add a cancer diagnosis and treatment on top of that, and it often really sets them back. The bottom line, I think the takeaway is that adolescents and young adults have extremely unique and unmet medical and psychosocial needs that we need to tackle from sort of both of those perspectives, both of those sides of the coin, to be able to provide good care for them. These are some of the common cancers that affect adolescents and young adults. So if you look on this side of the screen, we've got in that younger age range a lot of leukemia, lymphoma, some CNS tumors, thyroid, soft tissue, bone, that kind of thing. As you get a little bit older, that starts to change and you see more germ cell, testicular, things of that nature, melanoma, but leukemia and lymphoma is still pretty high. As you get a little bit older, right, then we're talking about more of breast and colon, cervical cancer, but you still have this kind of hodgepodge of other cancers that we talked about over here. So it's a wide age range with a lot of different kinds of cancer in it. And I'm going to skip that for a second. We'll come back to it. What I want you to take away from this slide is that this was from SEER data from 1975 to 1997, and this is the overall percent change in relative survival. And if you look at that 15 to 39-year-old age range that's circled right there, right here, we are not seeing a lot of improvement in survival rates in this age group. And in some cases, we're even seeing some decrease in survival rates. So that age range was largely defined because of some of this data. Now, why is that? And this is one of the things that the AOA oncology community is working on trying to figure out and is requiring more research to figure out. Some of it we know is the tumor biology. Their cancers are different. They're harder to treat. Some of it is delay in diagnosis because of their insurance status or sort of where they are in life, right? If you're a 20-year-old at college and you're experiencing some symptoms and your parents aren't there to sort of check in with you and shepherd you to a physician, you might be a little bit delayed in getting some of that checked out. Additionally, you might just not have access to care. Adherence to therapy is a big issue with this group for financial reasons, for sort of job reasons and school reasons, and just for where they are in life and the transient nature of where they are in life. There are a lot of psychosocial issues. This age group has more reported depression and anxiety and PTSD from their treatment. They have very low clinical trial enrollment rate. We could do a whole talk on that, and maybe we'll bring someone back soon to talk more about that. And the treatment protocols that are used for them vary. So they vary by site, they vary from peds to adults, and so there's just there are many variables in why we think they're not seeing the increase in survival rates. So I think the other thing to help us understand what's happening at this time of life is to sort of establish what's going on in terms of developmental tasks. So and I think probably a lot of you are thinking, well, 15 to 39, there's like 4 to 5 developmental stages that are happening within that age range. And that's one of the things that makes it tricky to develop programming and treat this age group. But I think there are some commonalities. And one is that you're establishing autonomy from your parents and your family of origin. You're sort of setting your own personal values and figuring out who you are as a person, your identity. You're developing really strong peer relationships, including intimate and sexual relationships. You're obtaining some kind of preparation to join the workforce, whether that is college or a trade school or just working at a job. And you're trying to have some financial independence. Now, I'm not a neuroscientist, but one of the things that I like to remind people is kind of what's happening in people's brains around this time. And your frontal lobe of your brain, which is the part of your brain that helps you reason and make decisions and understand consequences of your actions, doesn't finish completely developing until your late 20s. So I think it's helpful to understand, especially when working with this age group, when you're feeling some of these frustrations of like, why did you make this choice? Like, what are you thinking? Folks' brains just have not finished developing in that way. They don't have all the tools that older adults have in thinking through and reasoning through decisions. So I think it's helpful to have that sort of backdrop as we go through some of these issues that AOAs experience. All right, so we have our first question.
So what are some of the unique needs of AYA cancer patients? And you can just put in a word or two there, but let us know what you think are some of the unique needs that AYA cancer patients have. And if you'll take just a moment, again, this is completely anonymous, so pop in a word that you think fits for this, and then we'll take a look at that in just a moment. And not sure what's going on. Our poll just, our waiting disappeared there, so usually that means we've got, there we go. All right.
Body image is an excellent addition to that list. Yeah. Treatment decisions, relationships, absolutely. Yeah, lack of peers experiencing the same thing. So connecting with other cancer patients their age is a big issue. The numbers are quite small.
Mm-hmm.
Yeah, peer support is something that we are really focused on here, and how to connect AOA cancer patients to each other. Trust is huge, absolutely. These are fantastic. Social isolation, absolutely. I think feeling crummy is really tough, and especially when you see everyone's lives happening before you on social media while you're stuck in treatment is really hard. Lots of life transition, denial, absolutely. Getting financially stable. Yes, these are fantastic. These are fantastic.
Great. Thank you all so much for sharing all of those. That's very helpful.
Yeah, we're going to talk a little bit more in detail about a lot of these kinds of things. Fertility, yes. Thank you for whoever just put that up. We'll talk definitely about that in a few minutes. So the way that I like to structure these talks that I give around kind of unique needs of AYAs is to use quotes from patients. So I text back and forth with a lot of my patients. So a lot of these quotes come from text conversations that I've had with them. This one happened to be a piece that a patient wrote, but she said, "The simplest advice I can give to facilitate conversations with adolescents and young adults is this: be respectful and genuine. We are forced to confront our mortality at a time in our lives when society tells us that we're invincible, fearless, and limitless. When this construct crashes down around us and shatters, we can feel vulnerable." And there's just no way that I could say that any better than this young woman did. So that was sort of how beautifully and eloquently she put it. But I think this cartoon very nicely captures how a lot of providers can feel when taking care of AOAs. So there's Batman talking to Robin, looking at a Batmobile.
Yeah.
Not a Batmobile. And said, "Robin, this is not what I meant." And I think that this is how a lot of us can feel when we are taking care of AOAs. We think we're communicating one thing really well, and then they're not getting it or they're ignoring it, and it can be really frustrating. So we're going to talk about some sort of tips and tricks to deal with some of these things with adolescents and young adults. And you don't need an adolescent and young adult program at your facility to do these things. So I like to kind of lay that groundwork early on. So communication, and I think communication is the backdrop of everything that we're going to talk about today. How we communicate with them is extremely important. Honesty, we talked about earlier, is really important. I think it's important with any age range, but this age group in particular really needs transparency and honesty in the communication that you have with them. Legally understanding who you can and cannot talk to in their lives is extremely helpful. So when you've got, I think one of the things that we as providers forget often, especially with folks in their early 20s, is their parents are oftentimes involved in their care, but we don't get permission to speak to them, and we either assume that we can't speak to them or we assume we can, and we never have a conversation with the patient about who can we talk to, who can we share information with. Maybe they want to share information with their partner or their roommate, but not with their family. It's different for everyone. So setting those expectations and having that conversation early on is really important. Asking to see a patient alone, so making sure that you have time one-on-one with your AOA, and I think, here at UNC that's down to the age of 13, and even those 13-year-olds, we find that it's really important to ask their parents to step out of the room and give them some space, because in their sort of normal day-to-day life, they would have space from their family. They would not be with them 24 hours a day, and it's important to give them space and time to express thoughts, feelings, and ask questions they may not feel comfortable asking in front of their family. Non-judgmental. I think having a poker face is really helpful when working with this age group. Some wacky things can come up, and it's really important not to jump to conclusions, not to judge them, and not to react to those things when they share them with them. Avoid controlling and punitive language. I think it's we want to help this age group of people, and oftentimes what happens if they are non-adherent to treatment, for instance, is that a provider will think that if they threaten them, or if they say, if you don't do this, you're going to die, kind of thing, that of course that will cement this into their brains, and they will adhere to treatment in a different way. But as we talked about earlier, their brains really aren't meant to process and think through decisions like that. So to hear that from someone is actually not helpful. It's more helpful to think about what behaviors are they exhibiting, how can we address some of those behaviors and the root cause of them that are kind of contributing to lack of adherence, and we can talk more about some of those things in a little bit. Helping them best understand how they receive information is extremely crucial for this age group. They have often never interacted with the healthcare system before, and they don't know how best to receive information. They don't know how to ask questions of their medical team. Do they need things written down? Do they need things emailed? Is it best to have another person in the room with them hearing the information? So helping them understand how they learn and how they interact with the healthcare world is important, because they're going to be a part of it for the rest of their life. Repeating things over and over again, I think, is really helpful for anyone who's just gotten a cancer diagnosis, but especially for this age group. And one of the things that I like to do on that front is I'll just kind of take ownership of that when I'm talking with people, and I'll say, I can't remember if we talked about this before, and I just kind of own that I can't remember it, as opposed to them being on major information overload and only retaining 20 or 30% of a conversation that they hear, especially in the beginning of treatment. Your form of communication, I think, is really helpful. So the fact that I can text with patients is really crucial to my relationship with them. That's how they communicate with their peers and each other, and being able to do that with patients has made a big difference in their in terms of their ability to access support services. And then I think discussing things other than cancer, so understanding who that person is outside of the hospital and what motivates them and what is important to them, because all of those things are going to come into play in their cancer treatment. If they are a 25-year-old who is raising a 2-year-old and they're a single parent, that's going to impact their cancer care and their ability to work or their ability to have childcare. Understanding all of those things is extremely helpful in figuring out how to deliver care. So just a note about and we touched on this before, but about caregivers and partners and confidentiality and just sort of the legal aspect of this and understanding who we can talk to and who we can't, but also encouraging this age group to fill out healthcare power of attorney forms and to go through the legal steps that they need to make sure that they're protected, that their healthcare information is protected, that they have an understanding of what they want, and that others in their life have that too. And I think the best way to do this is just sort of set those expectations from the beginning. And there's a lot of gray, murky area in this. We could probably have a whole other talk just on this. But, I think the other piece of this is how do we support caregivers? So when we've got a 30-year-old member of the military and they're here with their spouse, how do we support that spouse? It is equally as hard, sometimes harder, to be a young spouse of a cancer patient or a young friend, they've never done anything like this before. They don't know how to support their person and how to cope with what's going on. There's a whole new language that they're learning. So the bottom line here is that AOAs require a different style and type of communication from providers. You have to be more flexible and engaged. Think about methods of communication. And that just to remember that this is a time in life where there are autonomy grabs. So you're going to see behavior from people where they are just trying to get some control in a situation where they have very little control. We have diagnosed them with an illness. We have told them exactly what they're going to need to do for treatment, when they're going to need to be here, what they can and can't eat, when they should sleep, how they should be living their life. And they are trying to find some way to have some kind of control in their life. So how can we give that to them? What does that look like? You know, when they're in the hospital, does it look like having some control over timing of when they participate in physical therapy, or some control over the food that they're ordering and eating, or the people that are coming to visit? Best case scenario, I would say think about when you're rounding on these folks inpatient and try and give them some control over that. They're not typically early risers, so if you want them to participate in rounds in a more meaningful way, try and figure out a time to come see them a little bit later in the day. So just any way that you can give them some flexibility in their schedule and treatment, I think is going to go a long way in building trust and a relationship, and also helping them feel a little bit more like themselves. So I think someone in the poll everywhere mentioned fertility treatment, fertility preservation. So this is a text I got from someone after we had a conversation about fertility preservation, and he said, "Can you come talk to me about that sperm thing?" And so I went and talked with him, and this is one of my favorite text messages I've ever received. So just again, we could give talks on each of these sort of issues that I've brought up, but as AOA survival rates are improving, the need to address fertility preservation is imperative. So in most circumstances, the cancer is not the cause of infertility or subfertility, but the treatment itself is what causes these things. So there are a lot of long-term side effects that could affect your sort of window of fertility and all these other things in your life that we need to educate patients on. So just some of the risks of infertility, I'm sure many who are listening are well aware of these things, but chemotherapy, surgery, radiation, and just people's age and fertility status coming into treatment, in addition to cancer types. Certainly some cancers affect fertility in different ways. So just one note about fertility preservation options, and I think it's important to say this as we're talking, is that it's extremely expensive. For men, it's around $400 or $500. For women, it's somewhere between $4,000 and $6,000. For women, it takes between 2 and 3 weeks to preserve fertility, and the combination of those factors makes it largely inaccessible to a lot of people. It doesn't mean we shouldn't have the conversations. So I think there's a lot of work in the AYA world, and we are participating in this as well, to advocate for insurance coverage for fertility preservation. It's not currently covered by insurance in North Carolina. But again, that doesn't mean that we shouldn't be having these conversations with patients. It is a NCCN guideline, and it's extremely important that they understand what their risk is and where that risk falls in terms of low, medium, and high risk in losing their fertility. So possible fertility outcomes are normal fertility, fertility followed by kind of early menopause, compromised fertility, immediate menopause, or permanent sterility. So there's a lot of things that could happen. And one of the things that I find is most important that we don't always do a great job of is following up with patients post-treatment. So we're getting much better at having these fertility conversations at the beginning of treatment. What we're not great at yet is following up with them when treatment ends to have their fertility status checked. So oftentimes post-treatment, patients assume either that they are infertile or everything's fine. And we don't do a great job of getting them to the right people to understand what their fertility status is. This is a huge issue. They need to understand that as they go through the rest of their life, as they meet new partners, as they establish that part of their life, so that they understand, is my fertility window shorter? Is it not? Is it not open at all? So I would encourage folks to try and make sure that we're following up with patients on this conversation, that we don't just have it on the front end. Second favorite text, what's the deal with having sex in the hospital? I got this text from a patient who, the 20-year-old who was admitted for his induction chemotherapy for treatment of leukemia, had a girlfriend and just wanted to understand, like, what are my options in the hospital? Just as an aside, I told him that there are no locks on the doors, but there are also no rules about this, so he would have to participate in that activity at his own risk and see what happened. But the other piece of that is that patients need to understand what the risks of having sex are when they are immunocompromised or when they have just had chemotherapy, and they need to be able to communicate those things to their partners. So it's important to have these conversations, and they can be really uncomfortable, but it's important to open the door, as uncomfortable as it is for some healthcare providers to initiate these conversations. Think about how uncomfortable it would be for an adolescent or young adult to bring them up in their healthcare team, in front of their healthcare team. We have to open those doors for them. And if they don't want to talk about it, they don't have to talk about it, but we have to inform them of what the risks are and how to safely have sex when they are in treatment. This is a part of their normal life, and it's a really big part of quality of life for people. Sexual health can change throughout treatment, and they need to understand what that's going to look like. There are lots of sexual side effects from treatment: fatigue, pain, restriction of movement, body image changes. I think someone mentioned that before. Just how are you feeling about yourself as a sexual person, and how do I engage with a partner in that way? Changes in physical appearance and weight loss and weight gain and functional issues, all of these play into the sexual side effects of treatment and need to be talked about with patients. I really like this model. I think it takes some of the sort of scariness of talking about sex and sexuality with patients out of the picture. So it's the better model, and you can read kind of what each of those are. But I think the piece that is really important is to include their partners in this conversation. So invite their partners to come and be a part of this conversation if that's something that they feel strongly about. Getting them in the room is really helpful. The next piece of this puzzle, AOA puzzle, is drugs and alcohol. So, or I would say we could also categorize as sort of other age-appropriate risky behaviors. So what if I just eat pot instead of smoke it, is one of the questions that my patients had. And patients have a lot of questions about marijuana. And again, if we don't bring it up with them, if we don't talk about it with them, they're going to get information from sources that might not be accurate. And they might do things in a way that are not healthy for them. And every provider has a different stance on this. It's sticky, right? This is a tough thing. There's not a lot of consensus. It's not legal in North Carolina. There's a lot of things, but we have to have these conversations. So there's not a ton of data about substance use in AOAs, but some indication is that substances are used to cope with stressors. So one of the things that we try to do here is talk about, how are you using drugs and alcohol? Are you using them to cope with how hard this is? And let's talk about some other tools that we could give you so that you could cope in a different, healthier way that's a little bit less risky. Again, these need to be really open and honest conversations, and we need to give them good options. I think the other thing to remember is that this is, aside from sort of substance abuse, substance use in this age group is developmentally really normal. And how do we rectify that with cancer care, and what that's going to mean, and sort of interactions with their therapy is the big question. So it's a tough thing to balance, but I think it's important to have these conversations with AOAs and to understand how drugs and alcohol and sort of the use of those things are impacting their life and kind of what they're using them for. Just as an aside, I'll give you kind of a great example that I feel like maybe sums up the last couple of things that we talked about. I had a patient who was getting ready for a bone marrow transplant, and his team said, "You're smoking too much weed. We need you to stop before transplant." And we had tried a lot of different things to help him cope. and hadn't really been successful. And one day he stopped me in the hall and said, "Hey, Lauren, I just want to let you know I stopped doing that thing." And I said, "What are you talking about?" And he said, "I stopped smoking weed." And I said, "That's great. Tell me what that was about. Like, what helped you do that?" And he said, "Well, it was really helpful to, talk to you guys about it." And he got onto an anti-anxiety medication, and that was really helpful. But he said, really, at the end of the day, my girlfriend told me she'd break up with me if I didn't stop. And this light bulb went on for me, and I thought, oh, yeah, we should have asked his girlfriend to be a part of this conversation way long ago. So, getting the important people in the room, I think, is key when working with these folks. So I also wanted to talk a little bit in this section about sort of exercise, nutrition, and lifestyle choices. So there's a lot of good literature that exists about how important it is for people to move when they're in treatment. And I think with this age group, one of the most important things is talking about what they can do, not just what they can't. So for instance, we have a lot of folks who come in who are involved in athletics, or they play basketball or football or baseball or lacrosse, and they can't play contact sports when they're in treatment. But we don't tell them what they can do, and largely we say, go for a walk. But what are some other things that they can do as young people who were previously really active? How can we help them integrate that into their treatment? And so on days when they are feeling good, they can move and they can do things that they know are safe for them. This will impact survivorship outcomes. It impacts mental health. And I think, the other thing to remember is that meals and often just, going to bars, that's all a social experience. And AOAs with cancer might find it harder to engage in those social experiences when they're dealing with nausea or when they're fatigued and their group of friends says, "Let's go out to dinner," and they just can't stand the smell of the food in the restaurant. So thinking through how all of these things impact their entire life is, I think, really important. So I think the question here with these behaviors is understanding when to intervene and when to normalize really age-appropriate behaviors. And I think that it's hard to tell where that line is all the time, and it's very individualized, but that's really the question for me with these kinds of behaviors. Remembering what's happening in peer relationships, remembering, I think, keeping in mind what's ideal and what we would love to have happen versus the reality of the situation. So I'll give you another quick example. I had a patient who was about a year out from bone marrow transplant and getting ready to go on a cruise with his friends, and he came to his follow-up appointment with bone marrow transplant team, told his doctor he was going on a cruise, and she said, "Why didn't you tell me you were going on a cruise?" And he said, "Well, I didn't really think I needed to. I'm a year out from transplant." And she said, "Okay, well, you can go." He was still dealing with some issues from transplant. She said, "You can go, but you can't drink." And this is a 23-year-old who is about to go on his sort of senior year of college cruise with his friends. And his face got really sort of flushed. And he said, "I can't drink?" And she said, "No, you can't drink at all." And I was with him in the room, and I said, "Well, I know he's hearing you, but what if he forgets what you say? Or what if he finds himself in a situation where he is drinking? What's a safe amount to drink? Is it nothing? Is it 1 or 2 drinks? What are some of the things he needs to look out for if he is drinking?" Again, just informing them of the risk of some of these behaviors instead of just saying, "Do not do them," or "Do not participate in them." And here we have another poll.
Right. So at your institution, what are some of the barriers to providing AYA appropriate medical and psychosocial needs? So again, thank you so much for the earlier responses, and we'd love to hear from you again. So at your institution, what are some of the barriers to providing AYA appropriate medical and psychosocial needs?
Lack of experience is so true, and I think some of it is that oftentimes, especially in the adult cancer world, we don't see a ton of these young patients, so not knowing how to treat them and deal with them is an issue. Insurance, absolutely, yeah. Access to care is definitely a big need. Money, yeah, finances, for sure.
All right, we'll take just another few seconds if you have anything else that you want to share on this topic. And want to remind everyone that at the end of the presentation, there'll be an opportunity for you to ask Lauren all sorts of questions. So be sure to be thinking about those and be ready at the end to share those questions with her. And here are a couple of more.
Yeah. I wanted to go back to money too. I'm wondering if that person was referring to just not having money at your institution to have an AOA program, or to have folks who are sort of specifically there to meet AOA needs, and that's certainly challenging. Lack of education and knowledge, not asking the right questions. Absolutely.
All right.
Yeah, absolutely.
Thank you all so much for engaging with this question as well.
Yeah.
I think we've got a couple of more before the Q&A and at the end as well.
Yeah. I think one of the things that I'll come back to later is that I understand that not all institutions are able to fund specific AOA programs. I do think that UNC is really interested in helping institutions who can't do that try to figure out how we can raise the level of care for these folks. So I would encourage any folks who are interested or are thinking about this in a different way to reach out to me. I'm happy to talk further about that, just so we don't lose that. So this is a quote from a 30-year-old that I was working with, and he was in treatment and said, I just don't think I can do this anymore. His disease was not curable, and he was trying to figure out how to communicate with his family about what he wanted at end of life. So I think we're going to talk a little bit about that right now. So just a little bit about decision-making and end-of-life care for AYAs. There's some pretty good data that AYAs largely are treated with some kind of intense measure at end of life. Chemo, ICU stay, ED visit, hospitalizations. 38% of AOAs in this 2015 study received chemo in the last 2 weeks of their life, and 65% died in acute care settings, which the data that we have on what AOAs want at the end of life is that they largely would like to die at home. So when we see that versus this very large number that die in acute care settings, there's definitely something that's not driving there. However, a lot of AOAs and their family enter the last month of their life wishing for prolonged care. They don't want to die. And I think that's one of the hardest things about this age group is that many of them express that they have not lived enough of their life yet, and their families feel the same way, and they want to do everything they can to extend their life. And also they don't know what their legacy is going to be, and we're going to talk a little bit more about that. So we could talk a lot about decision-making and end-of-life care. And in fact, our symposium in the spring, our AOA symposium in the spring, that is the focus this year, is palliative and end-of-life care among the AOA population. So if you want to learn more about that, I encourage you to come to that symposium. But what I want to talk about here is how do we help our patients tell their stories at end of life for themselves and for their families? And what tools do we have available to us to help them voice what is important to them? So there's a tool called Voicing My Choices. I'm going to show you an example of it in a minute. It's an advanced care planning document specifically for adolescents and young adults. You can find it online and order copies. It's a great tool to use with them. And I think the other piece that is important in this age group is to understand this tension between hope and realism. So oftentimes I get called because providers are concerned patients don't understand that they're out of treatment options and the end of their life is going to be coming sooner rather than later. And what I often find is that patients do understand that, but that they still, for their sort of spiritual needs and psychosocial needs and for their families, hold on to hope for what their future might be. So for instance, they talk about wanting to graduate from high school or college or have a family. And it's not that they don't understand what's happening to them, but they need to have hope and they need to hold on to that so that they can live the rest of their life in a meaningful way. So I just wanted to bring that example up. This is an example of Voicing My Choices. I know the text is a little bit small, but these are 2 pages as a part of that workbook. The first is what would I like my family and friends to know about me? And the second is how would I like to be supported? And I think, it goes through sort of the people they want with them and the things they want with them, and if they want music being played or things like that. All these things that are important to them. So it's a really nice tool that we use here. So I want to switch gears a little bit and talk about survivorship, transition and survivorship specifically. So this is a quote from a patient who said, I thought when I finished treatment, when they looked at my tests and said everything looked good, that I'm done. But now I'm starting to realize that it's not over. And this, I see more patients for individual therapy who are finished with treatment than when they are in active treatment. This transition from active treatment to survivorship is extremely difficult for adolescents and young adults. They had sort of a transient life that was up in the air and changing all the time before cancer treatment. They don't have a life that was well established to return to, and they're also different people, and they have to figure out how to weave this narrative into the life that they have. And what does it mean that I had cancer, and how do I talk to people about that? And I still don't feel great all the time. And I think the other piece of that is that they didn't have time during treatment to process what was happening to them. And I think this is common throughout the cancer world, and that, treatment is so rigid. This is when you come to treatment. This is what you're doing. This is for how long. And when it's over, a lot of people talk about this feeling of sort of being dropped off a cliff. And we're working on that here. And we have an adolescent and young adult cancer transition and survivorship clinic specifically for these patients. So when they finish active treatment, they come to us. They get a survivorship care plan, and they learn about what some of the challenges are of this part of treatment. It's really I like to think of it as another part of treatment. So there are 388,000, almost 389,000 child and adolescent cancer survivors in the U.S. And that's largely because the mortality rate has declined, which is fantastic. But 70% of these survivors are 20 years and older. So that's a large chunk of the population of that. We're going to skip a little bit of this just because we're running short on time. But suffice to say, there are a lot of medical and psychosocial issues that exist for AOA survivors. And I think one of the big pieces of the puzzle is that they get lost to care. So one of the things as providers that you can do is make sure that they are hooked in with good follow-up care, that they have a survivorship care plan to take with them wherever they end up geographically in life, and that they understand the importance of coming back to get survivorship care, not just for disease surveillance, but for some of these other health issues that we know cancer treatment can cause. I want to talk briefly about programming that you can do within your institution. So I hear a lot of people say that they don't have huge numbers of AOA patients, and they sort of come on different days of the week, and how do I introduce them to each other? One thing that we have found to be really beneficial here is to cluster care for these folks. So if you have 20 AOA patients that you're treating right now, can they come to clinic on the same day? Can we kind of rejigger schedules so at least they're in the waiting room at the same time, they see each other in the waiting room? This doesn't cost any money, and it doesn't require a ton of work. It's just a scheduling issue, so that's something to think about. An AOA advisory council, so understanding from patients at your institution what would be helpful to them. It's going to look different for every institution, and the best people to tell you about that are the folks who are living it. Having a social media presence can be helpful. Linking them to local and national AOA organizations, and I think I have some resources at the end of this presentation, and introducing them to peers is extremely important. We have a meetup group that happens the second Tuesday of the month. In the Triangle. If you go to our UNC AOA program page, the information about that event is on that page. Anybody can come. So if you have patients who are interested in that and want to meet other folks, it's very casual. It's not a support group. Happens at a restaurant. Grab food, drinks, and hang out and meet other people who are experiencing similar things to you.
All right, got another poll here. Name one practical change you can make in your work to better care for AYAs with cancer. So if you would take just a minute here to name one practical change you can make in your work to better care for AYAs with cancer. And this will be our last poll before our Q&A today. So thinking about some of the things that Lauren's been talking about, share with us one thing that rings true for you, something that you say, hey, that's something I could implement. I loved what you were bringing up about the clustering, the scheduling, and that doesn't cost any additional, there are no additional resources there aside from just really getting the people who do the scheduling on board with that. So and that's sometimes it's easy to be frustrated with all the things we can't do without additional resources, and so when there are those things that are relatively straightforward to implement.
Absolutely. Yep. Talk to them and not at them. I love that. Yes, that could be a title of a talk right there. Provide privacy for a patient. I think that's huge. Yeah, an open dialogue. These are great. Yeah, feedback from AOA patients. Yeah, on education initiatives. I love that idea. Yeah, I think not just programming, but that education piece is huge. And I think anytime you can engage your AOAs in teaching others at your institution about what they need, it's so helpful. If I had an AOA sitting here next to me, they would do a much better job of telling you about what it's like to be an AOA with cancer. So I think anytime we can get them to tell their story to make change is really powerful. Great. So I just wanted to list some resources for y'all to have, and you can come back to these. This is not an extensive list, but I think it's a good start in some of these buckets. My two best resources, I would say, are, in terms of online, are Stupid Cancer and Critical Mass. Those are great places to go. They keep their resource lists up to date, and you can kind of search by need. So those are fantastic ways to access some great resources that exist. So I think that's about it. These are some references. I'll leave the resources page up, and then we can take any questions that folks have.
Right, and we should probably, in order to see the questions, we're going to have to advance them.
Sounds good.
Whoops, too many slides. Let's see if I can get it there we go. But I will say that at unccn.org, we'll keep the slides up there that you've shared. So anyone who saw this or anyone who will see this in the future can go and get those slides and read over those.
Great,
so.
And I think my email address is on our UNC website, and definitely encourage people to reach out with any questions they may have via email or phone. I'm happy to talk anytime.
Great, thank you. So this is your opportunity for our audience, and you've been just amazing and engaged, and thank you for sharing so much. So Ed, please go ahead and share your questions via poll everywhere, and they're already coming in, so Laura, I'll let you take
so these are two questions around clinical trials. One is what clinical trials are ongoing at UNC for AOAs, and the other is the biggest barriers to enrollment. So I'll try to answer this question succinctly. It's a complicated issue. So there are a couple of different issues. I think the biggest barrier right now is that clinical trials are largely divided between pediatrics and adult medicine. And we don't talk well to each other in terms of those systems. So the biggest barrier in terms of what's happening at UNC and largely around the country is that it's very difficult to enroll young adults who are treated in the adult world onto pediatric trials, and many of those pediatric trials go up to the age of 30, 40, even 50, and vice versa. So trying to figure out how those two sort of siloed systems can interact with each other is one of I think the biggest barrier. In terms of clinical trials that are ongoing at UNC for AOAs, it's largely disease dependent. And if you go to, I think our pediatrics website has an updated list. I know that we are talking about keeping an updated list there, similarly for our adults. But specifically for AOAs, we don't have a just sort of AOA clinical trial list. It is something that we are working on, and it's something that's a goal for us in the next 6 or 8 months, is to make sure that that's easily accessible information for people. And then I see another question, do we deal with gender identity issues, and how do you handle this? Yeah, so yes, we do, absolutely. And I think largely how we handle this is just to be very sensitive and open to it and be able to have conversations with people. And I would say that one of the best things we can do is to ask people how they identify. And I think that's something that the healthcare world is working on in general, not just the AOA world, but just what do you identify as, and how would you like us to refer to you? And additionally, I think for me, the big piece of that puzzle is who are your partner, who is your partner, would you like them involved, and being respectful of that relationship and how we integrate that into their care. Yeah.
So we have a few more minutes for questions. I've got one or two while we're waiting for additional questions to come in from our audience. So as much as I would like to think that all of the things that you've been discussing have been fully integrated, the reality is they haven't been.
Sure.
As a clinician, as a patient, as a parent, or other caregiver, what should individuals do when they see things that really seem to be at odds with what the evolving needs of the AYA patient are?
I think the best thing you can do is just bring it up with your care team and ask what the avenues are to get those needs met. So I think oftentimes what happens is there are support resources, or there are resources that folks are not aware of, and it's sort of you don't know what you don't know kind of thing, and until you bring it up, often that need can't be met. So I think the best thing to do is bring it up and advocate, and sometimes it's a little bit more of a fight than you would want it to be. And largely I think that it's because we just don't have, some folks don't have as much experience dealing with this age group as others. So thinking outside the box in terms of problem solving is not always where we go as providers, because it's like, well, we do it this way and this is how we do it. And I don't understand, like, why should we do it a different way? So it requires some creativity that is not always our default as providers in a busy medical world. Right?
Okay. Well, we actually are getting towards the end of our time frame. Let me share a couple of other things before we wrap up. I want to say thank you, first and foremost, to you.
Thanks.
Thank you. This
Thanks
has been an amazing presentation, very comprehensive. I want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund, or UCRF, and also for their support of the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Mary King, Veneranda Obore, and John Powell, for all the work they do to make this and every lecture possible. We have more lectures, big surprise, always more. So coming up November 28th, our Med-Surg lecture, Understanding and Treating Anxiety and Depression in Patients and Families with Cancer, with Dr. Park. And starting with this lecture and for the foreseeable future, most of our lectures will now have pharmacy certification as well.
That's fantastic.
So we're adding that in. This one will have CME and the nursing and ASRT credit as well. So then RN and allied health complementary therapies in treatment of cancer. That's the tentative topic. We may shift that a little bit, and the speaker is to be determined, but we'll have that solidified in the next few days, and you'll find that on our calendar, December 12th. Self-paced courses. This course, all of our courses become self-paced free courses. Go to our site, take those for free, take the test, get the credit. It's very easy. So we now have available until September 4th, of 2019, recent advances in the gut microbiome and cancer therapy with Dr. Keiko, and understanding oncology drug interactions with Dr. Morgan. So those are coming up. And then, as I mentioned, for pharmacists, that ACPE credit, and we mentioned Dr. Park, and then the other two talks that are coming up soon.
Great.
So thank you so much.
Yeah, thank
Great
you.
to have
Thanks
you
for
here
having
today.
me.
All
Appreciate
right. Thank you to our audience. You've been wonderful. We wish you the best for a great Thanksgiving coming up, and we'll see you soon. All right. Thanks, everyone.